Every day, every single day, things are happening in the world of deals and deal makers. And there's never enough time to keep up with every company, transaction, announcement, or whatever. It's just exhausting. And we have a new product to help fix that. This is Axios Pro Deals, a new premium subscription product bringing you tailor-made insights like never before. For the last 5 years, Axios has helped deal professionals navigate the whole deal landscape with Pro Rata. With Axios Pro Deals, we're diving deeper into the industries that matter most to you. You just want stories on fintech? There's a newsletter for that. MedTech deals? We've got you covered. The future of retail? We'll guide you. With Axios Pro Deals, you're going to be getting all of this industry-specific insight and expert analysis at a level you simply can't get anywhere else. So if you're a venture capitalist, private equity investor, banker, trader, founder, executive, anyone who cares about deals, Axios Pro is what you need to help you understand what matters and why. Start your free trial today at AxiosPro.com.
Hello, and welcome to our Axios Vitals virtual event on addressing social determinants of health for older adults. I'm Adriel Bettelheim, Senior Healthcare Editor at Axios, and I'm coming to you from Albany, Maryland. I'd like to welcome our audiences on Facebook, YouTube, Twitter, LinkedIn, and on Axios.com. You can join our conversation today on Twitter with @Axios and hashtag Axios Events. Over the next 30 minutes, my colleague Tina Reed and I will explore how policies and social determinants affect health outcomes and care options for seniors. Our first guest is Congressman Raul Ruiz from California's 25th Congressional District. He's a member of the House Energy and Commerce and Veterans Affairs Committees and a Harvard-educated emergency physician. Welcome, Congressman.
It's wonderful to be here. Thank you.
The pandemic underscored the difficulties of caring for older adults. It's expensive, it's emotionally draining, we all know, and there are logistical challenges, and COVID only made things worse. If you were to say, what's the one thing Congress can do now to help seniors access care more equitably?
Well, there are numerous lessons learned from the pandemic. And one of the things that we understood was the importance of taking care to the people in their community or in their home. And that helped us move the ball of equity forward, because many of the underlying barriers that prevented seniors from getting care, like transportation, immobility, also were barriers for other communities that suffered the burden of disease at a higher proportion than other communities. So a very concrete short-term solution would be to extend the flexibilities that Medicare has on telehealth and telehealth in general from the Department of Health and Human Services, beyond the extra 2 years that we just did in the omnibus.
That's certainly telehealth. The explosion of telehealth is something that the pandemic has really accelerated, and so that would be your number one agenda item, I guess. With a divided.
So that would be one of the quickest short-term solutions. A number one agenda item, in addition to that, would be to combine a delivery system for home-based telehealth or tech medicine with community health workers. You see, if you get people from the community and train them, certify them to utilize the technology that we have to extend the care into people's homes, as well as doing routine checkup, social support networks, maintenance in terms of diabetes control and education, then you actually improve outcomes, decrease costs, and the patients are happier for it. And so that has shown to work during the pandemic in terms of utilizing the community health worker model to reach the hardest to reach, hardest hit, vulnerable populations from COVID-19 and to decrease the disparities that we saw with vaccinations. So if I were to pick a grandiose plan in helping our community get healthier, especially seniors, and improve their social determinants of health in terms of access to care, social networks, and check-ins in home-based care, that's the system that I would design.
It seems like it's going to take these sort of new care models, along with maybe value-based payments, to bring about change. I'm assuming with more big policy changes like Medicare expansion, politically not possible right now. Are you seeing signs that some of these innovations in your district, or as you travel around, are actually bridging gaps right now and making older adults more engaged in health promotion and disease prevention? Or are we still in a very experimental pilot stage and we've yet to see this thing really take root? What do you think? What are you seeing?
I'm seeing the results speak for themselves. So during the pandemic, as an emergency physician that coordinated with local nonprofits, including free clinics that I helped started called Volunteers in Medicine here in Coachella Valley, with other promotoras models, which is the community health worker model in Latina communities, we were able to take the vaccines and testing and health education to the homeless as well as the farm workers who traditionally do not have access to care, cannot afford the vaccines. And we saw an increased amount in one of the hardest hit, most vulnerable populations, the farm worker community, by taking care into their churches, their schools, their work sites, and actually in their neighborhoods. And we have high rates of vaccination, up to 98% in some of our rural, hardest hit, hardest to reach, unincorporated communities in my district. That's a model that can be taken to other places around the country. In fact, we saw the disparities in vaccination rate from between Hispanics and non-Hispanic whites narrow and almost to a point where it's no longer statistically significant. So the data is there, it works. In fact, this home-based community health worker or nurse visitations in the home has been studied by academic healthcare systems, insurance companies, and researchers to actually reduce readmissions, emergency department visits, reduce costs, improve outcomes for chronically ill patients. And so we really do need to take this healthcare delivery model, expand its policy to facilitate it into the home, into the community. Right now, all of the policy that we discussed is who's going to be paying for what at what rate. And so we need to start looking at how we deliver the care to keep our patients healthy, happy, and reduce costs.
COVID definitely surfaced these societal factors you're talking about: housing, transportation, food insecurity, that play such a big part in health outcomes. How do you get practitioners to apply that thinking when they see patients? You're a lawmaker, you're a doctor. Are doctors actually making referrals to social service agencies? Are the social service agencies able to handle the increased referrals if they are? What are you seeing?
Well, a lot of times patients that need follow-up care or that have issues with the ability to comply with the prescriptions or the recommendations get referred to a caseworker in the emergency department, and they get referred to a caseworker upon discharge in order to facilitate that follow-up. But the way that we start to help train physicians to have a holistic approach of healthcare delivery that takes into account the social determinants of health is to start educating them during pre-med classes, as well as medical school and in their residency training. Now, in some journals, there are case studies, for example, in the New England Journal of Medicine, that look at social determinants of health in the practice of medicine. Look, I'll give you a very clear example. Two examples, in fact. Education is clearly, or education level is clearly a social determinant of health. Those that graduate from high school live longer. Those that graduate from college live even longer. And so in my farm worker under-resourced community, there's a high dropout rate. When I saw patients coming into the emergency department as part of the social history, for adults, you usually ask if they smoke or how many drinks they have a day. For kids, you ask, are they being bullied or anything like that. I always ask, what college are you going to? And I get this look of surprise by a child who probably doesn't even know what college is, and their parent, as a farm worker like mine, probably didn't graduate from high school, and so they didn't understand why I was asking that question. So I took the opportunity to explain to them that, and the parents, that going to college helps not only their health, but helps improve their family's well-being and their family members' health. So that's a clear example how you can put the practice of understanding social determinants into your prescription, into your recommendation, into your care. The other example was when I would get a senior who's diabetic, who's overweight, and I would discharge them home from the emergency department, and I would give the recommendation of eat more healthy foods, more vegetables, fruits, and walk in your neighborhood a little more, as part of a regimen of helping to reduce their illness with diabetes. Now, of course, the farm workers that work here in the Coachella Valley oftentimes can't even afford the fruits and vegetables that they're picking in the fields. And many of them live in dilapidated farm worker trailer parks. So there is no place to exercise or walk. There's no pavements. The streets may not be safe. And so we have to take into consideration the context in which they live when we prescribe or give recommendations. In fact, it is because of that I, as an emergency physician, never held office before, never ran for office before, never even participated in a campaign before, decided to extend my care for my patients by running for Congress to address policy that will affect their well-being through the social determinants of health, improve their health, mental health, and opportunities to live a fruitful life.
Well, thank you, Congressman Ruiz, for joining Axios and for sharing your insights. We really appreciate it.
Thank you.
Next, we'll have a View from the Top segment with Chris Freites.
Thanks, Adriel, and thank you to our sponsor, United Healthcare, for making this conversation possible. And joining me now from United Health Group is their Chief Medical Officer and Executive Vice President, Dr. Margaret Mary Wilson. Dr. Wilson, thank you for joining Axios.
Hello, Chris, and thank you so much for having me today.
I'm excited to have this conversation, and I want to start kind of at a 30,000 foot level because I'm wondering, how does United Health Group improve the healthcare experiences for vulnerable beneficiaries? And I'm thinking here about seniors in particular.
Well, Chris, United Health Group is made up of two distinct and complementary businesses that work together to help build a modern and high-performing healthcare system, focusing on improving access, affordability, and quality of care for our beneficiaries. So we have Optum, which delivers care supported by technology and data that helps people and providers, gives them the guidance, the data, and the tools that they need to achieve better health. And then United Healthcare, which offers a wide range of healthcare benefits that supports affordable care and access to high quality of care, and also simplifies the healthcare navigation experience. So when we think about our Medicare Advantage beneficiaries, for us, it's about facilitating stable access to high quality care that's accessible and equitable. We think about the Medicare Advantage population, they are more diverse than Medicare fee-for-service. The Medicare fee-for-service population, about half of our Black seniors and half of our Latino seniors are enrolled in Medicare Advantage plans. They're also lower income. So about half of the Medicare Advantage beneficiaries earn less than $25,000 a year. So lowering the cost of care is important, and Medicare Advantage has actually been shown to do that by decreasing 40% of the out-of-pocket costs. And then finally, the Medicare Advantage population has more complex needs and a higher higher burden when it comes to chronic diseases. So enabling easy access to care is also a focus, and that's why our home care model, which we refer to as our house call service, is really an important focus for us.
Yeah, I want to talk to you a little bit about that because I think that's unique, a house call service. How does that program work, and what's its impact you're finding on seniors' health?
So the house calls program involves a nurse or an advanced clinical practitioner, advanced practice clinician, going into a beneficiary's home once a year. It's a free evaluation. It takes about an hour, and it involves both a physical examination and an environmental scan, right, of the home and the patient's natural environment. This comes together to enable a detailed health risk assessment that also covers off on social determinants of care. So it's a holistic approach. In 2022, we conducted over 2 million house calls, and nearly 1 million of the people we visited, we screened for undiagnosed conditions, and 1 in every 4 turned out to have a disease condition that they had not been previously aware of. And it doesn't stop there. 3/4 of those people were able to follow up with an in-person office visit with their primary care practitioner within 90 days. The other important thing about our house calls program is that it reaches into rural areas. So about 1/3 of 1 million of those visits were conducted in rural areas. Based on how effective it's been in 2022, we're actually expanding that in 23, moving from flu vaccines to include COVID vaccines, expanding our focus on social determinants of healthcare, and also expanding our in-home screening.
And I want to talk to you a little bit about something you mentioned. You talked about house calls being part of the holistic care. And I'm wondering, as a clinician, we hear about holistic care, and I'm wondering, why is it important to treat a patient holistically, and what does it actually look like in practice?
As a physician, over the years which I practice, it has become increasingly evident to us that health cannot just be considered the absence of disease. Health is life. It's the way we all live. And so it's really important that we take a comprehensive approach to it and consider social factors that impact that. And that's the added benefits of the Medicare Advantage program. It covers often benefits that are not provided within the traditional fee-for-service. So things like transportation, healthy food, for example, nutritional support, dental, vision, hearing. If we look at food, for example, and addressing the issue of food insecurity in elders, which is a really significant issue, in 21, we delivered 4 million meals to our Medicare Advantage patients. And we also provide meals after a patient has been discharged from hospital to support their recovery. In 2023, we're expanding this. We will be offering 14 meals after a Medicare Advantage beneficiary has been discharged. We also are offering transportation benefits because getting to a hospital or getting to a doctor's office can also be a challenge. A novel transportation model that we are launching this year, which we refer to as U-Ride, actually leverages best-in-class ride technology, working with internal and external partners to provide optimal transportation for beneficiaries who need to leave their home to access care. And then finally, utility payment assistance. We are enabling people to use their over-the-counter and healthy food benefits to actually pay for their utility bills.
Wow. So a lot goes into that holistic approach. And I wonder, with just a minute left here, what needs to be done to protect the Medicare Advantage program for America's seniors?
So the data actually does show that Medicare Advantage programs are driving benefits for seniors and for our dually eligible members with disabilities. And so at United Health Group, we believe it's a question of a matter of strengthening those practices and drawing on the best practices from the Medicare Advantage program. So it's really about the core tenets. How do we build those out? How do we strengthen them? How do we advance health equity as we build out innovative programs that support access and also drive equitable care? How do we expand access with additional benefits you don't get under fee-for-service, vision, hearing, transportation? How do we build person-centered innovative models, right? Value-based care models that truly ensure quality care? How do we support affordability and sustainability? And most importantly, how do we engage with partners, right? We should engage with partners, physician practices, accountable care organizations, community-based organizations, all of us coming together to help bring innovation and high-value care to beneficiaries.
Okay, we have to leave it there. Dr. Margaret Mary Wilson is the Chief Medical Officer and Executive Vice President for United Health Group. Dr. Wilson, thank you so much for joining Axios.
Thank you for having me, Chris.
And now, over to Tina Reed.
Thanks, Chris. I'm Tina Reed, Healthcare Editor for Axios. Our final guest today is the President and CEO of the National Hispanic Medical Association, Dr. Elena Rios, who's joining us today from Washington, D.C. Hello, Dr. Rios.
Hello, Tina. Good to be here.
I wanted to start by just introducing what the association does, who are you advocating for, and what are some of the top healthcare issues you're focused on right now?
Well, the National Hispanic Medical Association's been here in D.C. for 30 years now, almost. We formed with the Clinton White House, wanting to add a voice from Hispanic doctors and other health professionals that really know the community, come from our communities, and our access to healthcare is probably the number one issue. We've been the group without insurance, the largest group without insurance for years. And also prevention and education to our communities through our doctors. And, there's a lot of other things I could, big list. Of course, we need more research and documentation on subpopulations within Hispanics for everything from COVID-19 to infectious diseases and chronic diseases. And we also, and this is a big one for us, we very much want more diversity within health professions workforce.
Well, let's focus in on the pandemic and what some of the lessons we learned from that were, because obviously we saw that highlighted so many equity gaps. How have you seen this play out among Hispanic patients and specifically among the aging population?
Well, the aging population and seniors, let's say, have the most diseases, especially diabetes, heart disease, cancers. And they've been the most immunocompromised and were the most impacted by COVID-19. And especially living in multi-generational households where the essential workers in our communities had to go to work and had to face extreme burden of COVID-19 and getting it more than anybody else, whether they were in grocery stores or farm workers or meat packing plants. And not only that, we have lots of care workers in our communities that take care of the sick in their families. And and little kids. We have a young population with kids at school age. I think public schools in this country, 50% of the school age kids are Hispanic. So they bring viruses home. So the seniors are impacted from all types of factors in our community.
There were some benefits and flexibilities when it came to both telehealth and home care, and those obviously took on a new significance for the elderly. Can you talk about what that meant for Hispanic patients specifically?
Well, the telehealth is, the devil's in the details. In our communities, many people are not literate with health and health information, don't understand the importance of continuing to take medications because they feel better, even if they have high blood pressure or diabetes, and don't understand the Wi-Fi monitoring of weight, et cetera, for heart patients, let's say. But most importantly, our communities are low income, and don't have the wherewithal to be able to have good computerized systems, good internet, broadband, et cetera. So we really think there needs to be more technology focus on phone, cell phones, especially text messaging, some video consults. But I think the telemedicine world that we see with COVID-19, and we're going to continue to see, needs to adapt to low-income families more than anything. And I think, in terms of the other home care that you mentioned, it's very important to have home care that reflects the community. Again, having more community health workers, or what we call promotoras, be put into place in our health workforce with community health centers, as well as the health systems that are developing in our communities where they have bought up the private practices. We hope that more private practices would do what we learned in COVID was, they have lists of patients and have very strong rapport, the private doctors in our communities. And they were able to call and do house calls and continue to develop health care and medical care communications. And then the last thing I'll say, media is so important in our communities. So it's not just technology for the doctor, it's technology for the community that doesn't get to the doctor through Spanish language media and publications. We worked with Univision, Telemundo, as well as the U.S. Hispanic publications, getting to our communities with more accurate information, because misinformation is horrendous. Rumor mills and just bad information in general, we have to counter with better information, and with our doctors and nurses as the spokesperson, who are very trusted in our communities.
Well, and I wanted to dig in a little bit more on what actually may have worked during the pandemic as well. Obviously, we saw the public health emergency made some changes in accessibility for certain care. Can you talk about if any of that actually was actually helpful for the Hispanic community? And are there certain flexibilities that you hope stay in place after the emergency does end?
Yeah, the public health emergency allowed free vaccines, free masks, more funding to nonprofits such as NHMA and our partners. We were able to develop many grants to community organizations. And a lot of our national groups have been very much involved in education, public health education about the importance of vaccines, the safety of vaccines, and the importance of getting, antiviral treatments, tested treatment, for example, is a new campaign that we're involved with. And I think that when the public health emergency ends by the federal government, all the state governments already have their plans. I think they're expected to be given to the federal government next month in February. And by the end of the year, we're going to see many major changes because the public health education emergency ends. But more importantly, we're going to see people getting off Medicaid. Medicaid is the largest insurance in our country. I know that I think 1 out of 5 in America are now on Medicaid, and we have month-to-month enrollment that happened pre-COVID. And if there was a way to have better education and better connection to everybody on Medicaid, that they are going to be taken off Medicaid month to month to month, that they need to know about it ahead of time and need to know what they can do to stay on Medicaid if they are eligible. So that's a big piece. The other, I think technology, as you mentioned earlier, for medicine and healthcare is going to stay on Zoom and WebEx, and I think that's a plus, but we need the interoperability to be done that has not been done. We also need the licensing of doctors to be allowed to be used as it has been under the emergency system, where they could see patients in different states. We have farm workers that go from state to state, or we have people that actually live in different states now because everybody's working remote. So we definitely need to change the systems within healthcare to improve the quality of care, especially to the Hispanic families. They need more Spanish-speaking doctors in the technology space.
You wrote in Health Affairs last year about Medicare Advantage being a tool in the work of building a more just healthcare system, but you also said it wasn't a panacea. Can you talk about what you see as its benefits and shortcomings for this population?
Well, the biggest benefit, if you look at the data on Medicare and Medicare Advantage, which are both handled by CMS, the data part, like I said, Hispanics are still very much uninsured, 20% uninsured. But when you look at the Medicare population, there's about 5 million Hispanics that are in Medicare. 53% of those 5 million actually are in Medicare Advantage. So more than half are in Medicare Advantage. Why? The major reason is because it's a lower cost option than Medicare, because the insurance companies, it's a public-private partnership, so still run with CMS and the government, but because the private insurance companies are involved, they were given extra funding through the Affordable Care Act, reinsurance rates. I don't know all the formulas, but they were giving extra funding to be able to decrease premiums for the low-income plans and low-income people. And most of Hispanics are low-income, so the Medicare Advantage becomes a better opportunity. The other big positive was the whole idea of social determinants of health, like transportation to the doctor, transportation to your lab appointments, having some vouchers for food, especially fruits and vegetables with our food deserts in our poor communities. And then housing, having ramps built if you had disability, or having some type of air quality control, air conditioning, for example, pure air purifiers if you have asthma. These are the types of things that, most low income people do without. And this helps with quality of health. Many studies have shown that people would decrease their chronic diseases if they had better quality of life. So this is the good side of Medicare Advantage compared to Medicare. The flip side, though, it is a public-private partnership, and you have to deal with the nuances of insurance companies as they go from just billing companies to developing more consumer-friendly programming and getting the word out about the importance of staying with their doctors so that they can, not lose money. And I think the other thing is that there's been a lot of push to have better transparency with insurance companies through Medicare Advantage, and make sure that people know the quality of let's say, the authorization systems that are notorious for being denied, and what you do to have better data to show that, like racial, ethnic variables, for example, so that you do know that Hispanics or Hispanic subpopulations are actually getting better quality or less quality, whatever falls out in the data. But you don't know if you don't collect the data. And most of the data in this country is black and white and not Hispanic or Asian or Native American. So there's some work to be done for all of government insurance programs and insurance on the private sector for our communities to have better care.
Well, Dr. Rios, thank you so much for your time today.
You're welcome. Great to be here. And on behalf of National Hispanic Medical Association, we very much feel we're doing what we can to help our communities.
Thank you all for joining us this afternoon for another virtual conversation that has made everyone smarter, faster. For more information or to sign up for my Vitals newsletter, visit axios.com/newsletters or visit the Axios app. Thank you all for joining, and we'll see you next time on axios.com.